Hi everybody, and welcome to our module on hypoxia. The tissues of our body, as you know, require oxygen for metabolism, and therefore our bloodstream has to deliver sufficient oxygen. And oxygen delivery in the blood depends on two things. It depends on the cardiac output and also on the oxygen content of blood. So if you're going to deliver a sufficient amount of oxygen to our tissue beds, the cardiac output needs to be normal and the blood being pumped by the heart needs to have a normal oxygen content. This is all fairly obvious, but I state this just to get everyone on the right page for what we're going to talk about next. So let's talk about what determines the oxygen content of blood. The first thing is the oxygen binding capacity. This is how much oxygen our blood can hold, and this is determined by hemoglobin. The reason our bodies evolved to have hemoglobin is so that we could carry more oxygen in our blood than if we did not have hemoglobin. The second thing that determines the oxygen content is how much your hemoglobin is saturated. If you have lots of hemoglobin but it's only 10% saturated with oxygen, obviously you're going to carry less oxygen in your blood than if you were 100% saturated. And then the final component of oxygen content is dissolved oxygen that's directly dissolved in the blood, and this is a very small amount of oxygen. Most of our oxygen is carried bound to hemoglobin. So let's talk about some of the clinical measurements that we routinely make in patients to determine the oxygen status of blood. The first one is the PaO2. This is the partial pressure of oxygen in the blood. It's determined from an arterial blood gas. This is an image of someone obtaining an arterial blood gas here. You put a needle into the radial artery and collect a sample of blood, which is analyzed for oxygen content. And the PaO2 reflects the amount of oxygen dissolved in the blood, and normal is greater than about 80 millimeters of mercury. The second tool we use to assess the oxygen content of blood is the pulse oximeter. This is a tool that can measure the hemoglobin oxygen saturation of blood. And this is related to the PaO2. At the bottom right side of the screen is a hemoglobin saturation curve. I talk about these in detail in the video on hemoglobin, but what it shows is that as the PO2 goes up, the hemoglobin saturation goes up. So hemoglobin saturation is related to the PaO2, but it's a different measurement. And in order to obtain this measurement, we use a pulse oximeter, which has a light and a photodetector. You can place it on the finger like shown here on the screen, and this will give you a number like 75% or 80% or 100%, and that tells you how much of the hemoglobin in the blood is saturated with oxygen. We can actually calculate a number for the oxygen content of blood in milliliters of oxygen per deciliter of blood. We don't usually do this clinically, but for step one, it's important for you to understand the components that determine how much oxygen is found in our blood. So the first element of the oxygen content equation is the oxygen binding capacity. This is equal to 1.39 times the hemoglobin concentration. So what this means is the more hemoglobin you have, the more oxygen that you can potentially bind. You need to multiply this binding capacity by the percent saturation that we talked about earlier from the photodetector. If you have lots of hemoglobin but it's only 10% saturated, that doesn't represent much oxygen content. On the other hand, if you have lots of hemoglobin and it's 99% saturated, then you do have a lot of oxygen content in your blood. And then finally, we add the dissolved oxygen amount, which is equal to 0.003 times the PaO2. This is a very small amount of oxygen. Our bodies have evolved hemoglobin so that we can carry much more oxygen than we could if we were only able to carry the amount that dissolved into the blood. So the bottom line here of this equation, what you need to understand to answer step one questions, is that normal oxygen content requires the presence of adequate hemoglobin, a sufficient saturation of hemoglobin, and then finally a normal PaO2, because remember, the PaO2 not only determines this portion of the equation, it also determines how much saturation you will have of hemoglobin. Let me go through a little vocabulary. When we say a patient has hypoxemia, we mean there is a low oxygen content of the blood. This usually means someone who has either a low PaO2 or a low hemoglobin saturation percent. When we say hypoxia is occurring, that means there's low oxygen delivery to tissues. And we'll talk in a minute, but you can have hypoxia without hypoxemia in certain scenarios. And then finally, when we talk about ischemia, we're talking about the loss of blood flow, just like when we talk about ischemia in the heart from a myocardial infarction. So a normal hemoglobin oxygen saturation is about 98 or 99%. If a patient has a low hemoglobin oxygen saturation, let's say 50% or 40%, then that patient has hypoxemia. Similarly, if you do an arterial blood gas and a patient has a low PaO2, then that patient also has hypoxemia. And hypoxemia can lead to hypoxia, meaning low delivery of oxygen to tissues. However, you can have hypoxia without hypoxemia, as I said before. There are certain scenarios where the PaO2 can be normal or the hemoglobin saturation can be normal, but there is still hypoxia, and that's what we're going to talk about in the next few slides. So shown at the bottom of the screen are the four common hypoxia causes. The first one is hypoxemia, of course, but the next three cause hypoxia without causing hypoxemia. These are heart failure, anemia, and carbon monoxide poisoning. So patients with heart failure have a low cardiac output, and this can lead to decreased blood flow to tissues, which can cause hypoxia, meaning you're not delivering sufficient oxygen. Heart failure patients can have normal oxygen content of their blood if they're not in pulmonary edema and not having any respiratory complications of heart failure. And in these scenarios, the PaO2 and the hemoglobin oxygen saturation can be normal. So for example, patients of mine with end-stage heart failure awaiting heart transplantation can have cold fingers and cold toes. That's because not enough blood is being delivered to those distal parts of the body. Those fingers and toes can experience hypoxia. Sometimes they can turn blue or even black. And yet, if I do an arterial blood gas, those patients may have a normal PaO2. So in those scenarios, we don't have a problem getting oxygen into the blood. We have a problem delivering the oxygen in the blood to tissues. Anemia is another classic cause of hypoxia without hypoxemia. In patients who are anemic, the oxygenation of blood by the lungs is totally normal, but the carrying capacity is reduced. For this reason, these patients have a very low content of oxygen in the blood, even though their PaO2 and hemoglobin saturation is normal. So these patients have a normal PaO2 and their hemoglobin may even be 98% or 99% saturated, but they still have hypoxia because there are just relatively few hemoglobin molecules in their bloodstream. And then finally, carbon monoxide is another classic cause of hypoxia without hypoxemia. Carbon monoxide is a gas, and patients that inhale this gas can become very sick from tissue hypoxia. The problem with carbon monoxide is it binds to the iron in heme with 240 times the affinity of oxygen. Because it binds so avidly, it blocks the oxygen binding sites and creates what's known as a functional anemia. Basically, even though there's enough hemoglobin present, so much of the hemoglobin binding sites for oxygen are blocked that the patient behaves as if they are anemic. The alveolar PaO2 is usually normal. That's because the amount of carbon monoxide gas required for poisoning is very small. It doesn't take up much room in the alveoli, and it leaves the oxygen concentration in the alveoli normal. And when you have normal oxygen concentration in the alveoli, that leads to a normal P-little-ao2, which is the oxygen concentration in the arteries. So these patients can have a normal PaO2, but oxygen is failing to bind to hemoglobin normally because many of the binding sites are blocked. Patients with carbon monoxide have a low saturation of hemoglobin with oxygen. That's because carbon monoxide blocks those oxygen binding sites like we just talked about. The problem that this creates clinically, though, is that the pulse oximeter often shows a normal oxygen saturation. That's because it can't distinguish between hemoglobin bound to carbon monoxide and hemoglobin bound to oxygen. So it will say that hemoglobin is 99% saturated. It won't be able to tell you that only 50% of that saturation is from oxygen and the remainder is from carbon monoxide. So the net result of all this is that the oxygen content of blood is reduced because carbon monoxide is blocking binding sites for oxygen. So I've summarized the key findings of carbon monoxide poisoning at the bottom of the screen. Patients will have a normal PaO2. They have a low oxygen saturation in reality, although they can have a normal oxygen saturation by the photodetector that measures the hemoglobin saturation. And this all leads to hypoxia, even though they may apparently not have hypoxemia. Shown on this slide is a table listing the causes of hypoxemia, and many step 1 questions derive from the information on this table. Don't just memorize it. Make sure you understand it. So the first cause of hypoxia is hypoxemia. Patients with hypoxemia have a low oxygen content of the blood, low PaO2, and low percent saturation. In patients with heart failure, the oxygen content, PaO2, and percent sat can all be normal. The problem is the low cardiac output. Anemic patients have low oxygen content, but their PaO2 and their percent saturation are normal. And then carbon monoxide patients behave very similarly to anemic patients. They have a low oxygen content of blood, a normal PaO2, and a low percent sat, although I put an asterisk here because, as I told you, the photodetector may erroneously say that the oxygen saturation is normal. For the remainder of this video, I'm going to talk about hypoxemia. Hypoxemia means a decreased oxygen content of blood, and it always indicates a defect oxygenating blood in the lungs. There are many causes of hypoxemia. We'll talk about lots of them in this video, but they're all categorized by their AA gradient. So the AA gradient is the difference between the alveolar partial pressure of oxygen minus the arterial partial pressure of oxygen. You can get the P big AO2 from the alveolar gas equation. We'll talk about that in a minute. And you can get the P little AO2 from an arterial blood gas like we talked about a few slides ago. To understand the AA gradient, let's take a look at this drawing I've shown on the slide. I've drawn an alveolus in blue, and in red is a pulmonary capillary with blood flowing past the alveolus from left to right, picking up oxygen. If we're at sea level, breathing normal 21% air, the partial pressure of oxygen in inspired air is 150 millimeters of mercury. Now you might think because we're inspiring air with this oxygen concentration that we'd find the same oxygen concentration in the alveolus, but that's not the case. The oxygen concentration in the alveolus in a healthy person with normal lungs is about 100 millimeters of mercury. And the reason the P big AO2 is lower than the inspired oxygen is because carbon dioxide fills up the alveolus and displaces some oxygen, and oxygen is also taken up by blood in the capillaries. So the net result is a lower alveolar oxygen content compared to inspired air. Now, blood that is entering the pulmonary capillary is coming from the venous system in the body, and blood in the venous system has a PO2 of about 40, and hemoglobin is about 70% saturated with oxygen. As blood moves through the pulmonary capillary, it completely equilibrates with the air in the alveolus. That means that blood leaving the pulmonary capillary will have an oxygen concentration of 100 millimeters of mercury, just like what you find in the alveoli. However, if we do an arterial blood gas and we measure the oxygen content in the arteries, in other words, the oxygen content after blood has left all the pulmonary capillaries and mixed together, what we find is that it's not 100. It's lower than 100. It's usually about 90, which is still enough to fully saturate hemoglobin, but nevertheless, it's lower than the alveoli. And the difference between the alveolar O2 of 100 and the arterial O2 of 90 is called the AA gradient, and normal is about 10 to 15. And the reason we have an AA gradient is because not all the blood in our body flows through a pulmonary capillary to equilibrate with an alveoli. There is some venous blood that bypasses the pulmonary system and flows directly from the venous side into the artery side, and that dilutes the concentration of oxygen so that even though it's 100 coming out of the pulmonary capillary, when it mixes with this blood here in the arterial system, you find that the oxygen content is about 10 or 15 millimeters lower, and that's what makes the normal AA gradient. In the video on ventilation and perfusion, I talk in detail about the alveolar gas equation, which is shown on this slide. According to this equation, the alveolar oxygen content is equal to the inspired oxygen content minus the alveolar CO2 content divided by a constant R. For patients breathing room air oxygen at sea level, the PiO2 is 150 and the constant R is 0.8, so now if we just know the alveolar concentration of CO2, we can determine the alveolar concentration of oxygen. Now we have no way to directly measure the alveolar concentration of CO2, so instead what we do here is we use P little a CO2, which is the concentration of CO2 in the blood, and we use that in place of the P big A CO2. Essentially these two numbers are equal, and since there's no way to measure the P big A CO2, we just use the P little a CO2 in this equation. So shown on this slide are the directions for how to determine the AA gradient. Remember that it's the difference between alveolar and arterial oxygen, and it's helpful for evaluating hypoxemia, which we'll talk about in a minute. So step one is to perform an arterial blood gas and measure the arterial oxygen content and the arterial CO2 content. You then use the alveolar gas equation to determine the P big AO2. Once you know this, you can determine the AA gradient by subtracting the P little AO2 from the P big AO2. And a normal AA gradient in a healthy person is about 10 to 15. The reason for the normal AA gradient is because some blood in our body that goes to the arterial system drains from the Thebesian veins and the bronchial veins. The Thebesian veins drain a portion of the left ventricle, and the bronchial veins drain the bronchi. Blood in these systems does not pass by alveoli and goes directly into the arterial system. Therefore, it dilutes blood coming from the pulmonary capillaries, and that results in the normal AA gradient of about 10 to 15. Let's start by talking about causes of hypoxemia associated with a normal AA gradient. And the thing you must understand about hypoxemia with a normal AA gradient is that it is always caused by a low alveolar oxygen content, meaning a low partial pressure of oxygen in the alveoli, which is P big AO2. So let's go back to this slide we went through earlier with an alveolus and a pulmonary capillary. And earlier I told you that a normal alveolar oxygen content is about 100, and that yields an arterial oxygen content of about 90, and the difference between 100 and 90 of 10 is the AA gradient. Well, now I want you to imagine that the alveolar O2 falls and becomes 70. Well, we still have our normal AA gradient of 10, but that's now going to give us an arterial oxygen content of 60, and therefore we have hypoxemia, but the AA gradient remains the same, and it's all caused by a low alveolar oxygen content. So now you may be asking yourself, well, what could cause a low P big AO2, in other words, a low alveolar oxygen content? Well, everything you need to know to answer that question is shown on this slide in the alveolar gas equation. There's only two ways you can get a low alveolar oxygen content. The first way is if you don't inspire enough air, in other words, if the PiO2 becomes low. And so that's the first way you can get a low alveolar oxygen content, and hypoxemia with a normal AA gradient if there's a decreased amount of oxygen in inspired air. The second way that you can get a low P big AO2 is if you have a high carbon dioxide level. And when do you get a high carbon dioxide level? That's when you hypoventilate. Hypoventilation always causes elevated carbon dioxide, and I talk about this in great detail in the video on ventilation and perfusion. So if you are hypoventilating, then your CO2 level is going to go up, and according to the alveolar gas equation, that will lead to a low PaO2, and a low PaO2 leads to hypoxemia with a normal AA gradient. So back to this slide, and as I was just saying, there are only two causes of hypoxemia with a normal AA gradient. The first one is decreased oxygen content of inspired air, and this is what happens when you ascend to high altitude. If you're breathing room air at sea level, the PiO2 is about 150, and remember the PiO2 is in the alveolar gas equation. It determines the PaO2. If you ascend to high altitude and go high enough, the PiO2 can become as low as 100. So when this PiO2 becomes very low, that's going to decrease the PaO2 and cause hypoxemia at high altitude with a normal AA gradient. The second cause of hypoxemia with a normal AA gradient is hypoventilation. This can occur if patients have a reduced respiratory rate or a reduced tidal volume. Any cause of hypoventilation is going to increase the PaCO2, and that is going to decrease the alveolar oxygen content, all according to this equation on the screen. When the PaCO2 goes up from hypoventilation, that will decrease P big AO2, leading to hypoxemia with a normal AA gradient. And hypoventilation can occur for many reasons. Narcotics suppress the respiratory rate. Patients with neuromuscular weakness cannot have enough muscular strength to draw in breath. And then finally, obesity is a classic cause of hypoventilation. And if you understand everything I just said on the last slide, then it's easy to understand that hypoxemia with a normal AA gradient always improves with oxygen. If you administer oxygen to patients, you increase the PiO2, and that is always going to raise the P big AO2, and therefore that is going to improve hypoxemia associated with a normal AA gradient. If you give oxygen to patients who are hypoventilating or patients at high altitude, that will always resolve the hypoxemia. Now let's talk about hypoxemia with an increased AA gradient. In these situations, there's no problem with alveolar oxygen content. The PaO2 is not decreased. The problem that causes hypoxemia with an increased AA gradient is that the arterial oxygen content becomes low. That's the P little aO2. So let's go back to this slide. In hypoxemia with an increased AA gradient, the alveolar O2 is not decreased. It can be normal or even increased in some situations when patients hyperventilate. The problem in hypoxemia with a high AA gradient is that the arterial blood develops a low oxygen content. So instead of 90, maybe it goes down to 60. When this happens, you're going to have hypoxemia, but the AA gradient is going to be increased because the alveolar oxygen content has not changed. So most primary lung diseases have a high AA gradient. Disorders like pneumonia, pulmonary edema, COPD, pulmonary fibrosis, all these conditions cause hypoxemia with a high AA gradient. There's no problem getting oxygen into the alveoli. The problem is getting oxygen into the arterial system. And there are three basic underlying mechanisms that cause hypoxemia with a high AA gradient, and that's what we'll go through in the next few slides. These three mechanisms are diffusion defects, shunt, and VQ mismatch. So let's talk about diffusion problems first. Gases must diffuse from the air in the alveoli into the blood in the pulmonary capillaries. And the rate of diffusion depends upon three things: the pressure difference between oxygen content in the air and the blood, the area of the alveoli that's available for gas diffusion, and the thickness of the alveolar tissue. So let's take a look at this drawing I've made on the screen, and let's imagine that on the left side we have oxygen contained in the alveoli, and on the right we have oxygen contained in blood in a pulmonary capillary. Well, as I told you before, the oxygen content in the alveoli is about 100 millimeters of mercury, and the oxygen content in the pulmonary capillary blood when venous blood first enters the capillary is very low. For example, it can be as low as 40. So what's going to determine how much oxygen is taken up by the blood? Well, the first thing is the difference between the partial pressures, the difference between 100 and 40. Gases always diffuse from high concentrations to low concentrations, so this difference of 60 millimeters of mercury is going to drive diffusion into the blood. The second factor that's going to determine how much gas can diffuse is the total area available for uptake of gas. The more area you have, the more gas molecules can pass from the alveoli into the blood. And then finally, the thickness of the walls of the alveoli through which gas must diffuse is also going to determine how much gas is taken up. If this thickness is very large, it's going to be difficult for molecules to pass through, and less gas is going to enter into the bloodstream. So if you understand all those things, it's easy to understand the gas equation, which tells you how much volume of gas per time is taken up by the blood. The volume for time is proportional to the area, a diffusion coefficient that's specific to a gas in a particular system, the difference between P1 and P2, and it's divided by the thickness. And all the things I just said are apparent from this equation. More area leads to more gas diffusion, a bigger gradient leads to more gas diffusion, and more thickness leads to decreased gas diffusion. So if there's a diffusion limitation, that is going to lead to hypoxemia with an increased AA gradient. And there's a couple of reasons this can happen. In patients who have emphysema, the alveoli are destroyed, so the surface area for diffusion decreases. In pulmonary fibrosis and pulmonary edema, the thickness of the alveolar walls increases, and that's going to limit the amount of gas that can diffuse. But the bottom line here is that any problem that leads to decreased diffusion, that is going to cause hypoxemia, and it's going to cause a high AA gradient. So let's go back to this slide. When you have a diffusion limitation, the PaO2 is not reduced, but the problem is that oxygen can't make it out of the alveolus into the pulmonary capillaries, and therefore the PaO2 falls. For example, it could get as low as 60, and then what we're going to have is hypoxemia with a high AA gradient. So back to this slide, I told you there are three basic mechanisms that cause hypoxemia with a high AA gradient. We just talked about diffusion defects. Now let's talk about the last two, which are closely related, and that is shunt and VQ mismatch. In the video on ventilation and perfusion, I talk in detail about the ventilation to perfusion ratio, also called the VQ ratio. This is equal to the alveolar ventilation in liters per minute divided by the pulmonary blood flow in liters per minute. And matching of ventilation to perfusion in all portions of the lung is critical for gas exchange. If you have parts of the lung that are either underventilated or underperfused, this leads to inefficient gas exchange. So in a shunt, you have a portion of the lung affected by disease where there is no ventilation. As a result, there's an extreme reduction in VQ so that the VQ ratio for that sick portion of the lung becomes 0. What this means is that blood flowing to this portion of the lung is going to go directly from the venous system to the arterial system without ever becoming oxygenated, and that is going to lead to hypoxemia with an increased AA gradient. I told you earlier that the cause of the normal AA gradient is that some venous blood does not go through pulmonary capillaries and past alveoli. Some venous blood normally bypasses the alveoli, and that's what causes the normal P(a)O2 to be about 90 and the normal AA gradient to be about 10. Well, now imagine that more venous blood is bypassing the alveoli. That's going to dilute the arterial blood even further, so instead of a P(a)O2 of 90, it might become 70 or 60. And when that happens, because the P(A)O2 is not changing, you are going to develop hypoxemia and you are going to have an increased AA gradient. So just to make shunting very clear, let's imagine that we have a system with two alveoli, one here and one here, both drawn in blue, and there is a pulmonary capillary with blood flowing past each alveoli. On the left, blood enters the pulmonary capillary desaturated. This is venous blood that's only 70% saturated with oxygen, but after it passes through the alveolus, it becomes fully saturated. Same thing happens on the other side, and when the two streams mix, we have fully saturated blood in the arterial system. Now let's imagine we develop a pathologic process and we shut off ventilation to this alveolus on the left. What's going to happen is the VQ ratio on the left is going to become 0. Blood will enter that capillary with 70% oxygen saturation, and it will leave with the same saturation because it doesn't pick up any oxygen. The other capillary will continue to work normally, but when the two streams mix together in the arterial system, you will have hypoxemia. And that's what happens with shunting. You develop hypoxemia because venous blood goes directly into the arterial system. Now let's imagine we administer 100% oxygen to this patient to try and resolve the hypoxemia. Well, let's look at what's going to happen. On the left, you have shunting. There's no ventilation, so none of that oxygen is going to get into that pulmonary capillary on the left. On the right, you're already fully oxygenating the blood, so increasing the oxygen content in the alveoli to 100% makes no difference. And that's a huge point about shunting. The hallmark of shunting is hypoxemia that does not improve with 100% oxygen. If you're given a case on step 1 where the patient is hypoxemic and oxygen doesn't make a difference, the mechanism of hypoxemia is always shunt. It's the only condition that causes that. So now that we've talked about shunt, let's talk about the final of the three mechanisms of hypoxemia with a high AA gradient, and that's called VQ mismatch. So if the VQ ratio becomes low, it becomes less than 1, this means you have reduced ventilation relative to perfusion. It means perfusion is being wasted. Blood is going where there's not enough oxygen present. And we just talked about the extreme version of low VQ. That's when the VQ becomes 0, and that's a shunt. In VQ mismatch, the VQ ratio is still reduced, but it's not 0. So this is just like shunt, however, it's not so severe that you have a VQ ratio of 0. When patients have this problem, they will develop hypoxemia with a high AA gradient, but in contrast to shunt, this will get better with oxygen. To make this more clear, let's go back to our diagram of two alveoli with two pulmonary capillaries. What I've shown here is that some problem has developed due to disease that has impaired the inflow of air into the alveolus on the left. There's still some air getting in. It's not completely shut off like in shunt, but the amount of air that gets in, the ventilation, has decreased so that the VQ ratio on the left side is going to be low. Well, let's talk about what's going to happen. Now, let's go through the normal side on the right first. Blood's going to enter at 70% oxygen saturation. It's going to leave fully saturated, and then it's going to head out into the arterial system. On the right side, blood is going to enter at 70% oxygen saturation. It will leave with slightly more oxygen, but it will not be fully oxygenated. For example, it may get up to 80% oxygen saturation. When these two streams mix in the arterial system, that's going to lead to hypoxemia. So this physiology is very similar to shunt, but the key difference is if you give this patient 100% oxygen, some of it is going to get into that alveolus on the left. That is going to improve oxygenation on the left side so that instead of 80%, maybe you can actually get up to 100% over here. And when you do that, the hypoxemia is going to go away. So VQ mismatch is a pseudo form of shunt, but the key difference is it responds to oxygenation because there is still some ventilation. We've been talking a lot about oxygen in this module, but let me briefly mention carbon dioxide. In the video on ventilation and perfusion, I talk about how there are only 3 causes of hypercapnia: hypoventilation, increased dead space, and increased carbon dioxide production. And this is what you always want to remember for step 1. In general, the causes of hypoxemia with a high AA gradient do not cause an elevated CO2 level. Patients can have diffusion limitation, they can have a VQ mismatch or a shunt, as long as they are ventilating their lungs normally. In other words, as long as they are not hypoventilating, then their CO2 level should remain normal. Here's a table summarizing the mechanisms of hypoxemia associated with a high AA gradient. There are 3 of these: diffusion limitation, shunt, and VQ mismatch. All 3 conditions are associated with a low P-little-a-O2, meaning they are all associated with hypoxemia. In all 3 conditions, PaCO2 usually does not rise. The main distinguishing feature is what happens when you apply 100% oxygen. If you apply 100% oxygen and it results in no change in the arterial oxygen content, then you have a shunt. If you apply 100% oxygen to a patient with VQ mismatch, the oxygen saturation will go up. Oxygen helps patients with VQ mismatch. And finally, oxygen also helps patients with diffusion limitation. And to understand that, let's look at the diffusion equation again. In this diagram, I told you the alveolar partial pressure of oxygen is P1 on the left side. Well, if we administer oxygen, P1 is going to go up. And then according to this equation, with a higher P1, we're going to get more diffusion. And therefore, patients with diffusion limitation also improve when you administer 100% oxygen. And here's another table summarizing the mechanisms of hypoxemia and showing you the changes that occur in the arterial oxygen content and the alveolar oxygen content. This table is super high yield for step 1. Many questions derive from this. So patients with hypoxemia and a normal AA gradient are hypoxemic, so their P-little-a-O2 is decreased, but their alveolar O2 is also decreased. And because both are decreased, the AA difference is going to be normal at 10 to 15. In patients who have an increased AA gradient with hypoxemia, they are also hypoxemic, so arterial oxygen content is low, but their alveolar oxygen content has not decreased, and for this reason the difference between the alveolar and arterial oxygen content is increased and the AA gradient is high. Most common disorders we see clinically, like COPD and pneumonia and pulmonary edema, have hypoxemia through multiple mechanisms. For example, patients with pneumonia can have VQ mismatch, they can also have shunt, they can also hypoventilate. So you're not going to be asked on step 1 for a patient with pneumonia, what's the mechanism of hypoxemia? There are a couple of examples that I think are worth knowing. Patients who have an intracardiac shunt, like an ASD or a VSD, develop hypoxemia from a pure shunt mechanism. They do not have VQ mismatch, they do not have diffusion problems. A child who inhales a peanut cuts off ventilation to a portion of the lung, and the VQ ratio in that section of the lung becomes 0. So hypoxemia in this setting is also due to a pure shunt mechanism. And then the final example that I think you should know for step 1 is pulmonary embolism, so let's talk about that now. I have an entire video on pulmonary embolism, but by way of review, in a PE, there's a blood clot that obstructs flow in the pulmonary vasculature. At the bottom right side of the screen is a CT angiogram of a patient with a pulmonary embolism. This dark stuff here is sitting inside the pulmonary artery, which is this area in white, and it's obstructing blood flow. When you have no blood flow to a portion of the lung, but it's still ventilated, that creates dead space, and patients with pulmonary embolism definitely have an increase in dead space. But remember what I said before, dead space can cause elevated CO2, but it does not cause hypoxemia. So the mechanism of hypoxemia in pulmonary embolism is not increased dead space. Don't pick that as the answer, it's not correct. The reason that some patients with pulmonary embolism develop hypoxemia is because of VQ mismatch, and it's super high yield to know this. I'll explain it to you, but even if you don't understand it, just memorize it. In patients with pulmonary embolism, what happens is blood flow cannot move through parts of the lung. So all of the blood is forced through the remaining open vessels. This increases the perfusion, the Q, through those working vessels, yet they still have the same ventilation. As a result, the ratio of ventilation to perfusion becomes low, and that's VQ mismatch. And it is that low VQ mismatch in the healthy parts of the lung that causes hypoxemia. It's not dead space, even though there is dead space in pulmonary embolism. So just to make this super clear, because this is such a high yield point, what happens to most patients with pulmonary embolism is they develop VQ mismatch. This is going to lead to hypoxemia with a low level of oxygen in the blood. The hypoxemia is going to cause the patients to hyperventilate, so their respiratory rate will go up. And then because they are hyperventilating, their CO2 level is going to get low. Most patients with pulmonary embolism present with hypoxemia and a low CO2 level. There is dead space present for sure, but the dead space does not cause hypercapnia because the respiratory rate gets high enough to overcome the dead space, and in fact, actually what usually happens is the carbon dioxide level gets low. Make sure you understand everything I've written here on this slide. This is super high yield. It comes up in all your step exams, medicine exams, emergency medicine exams. These are the classic findings on a blood gas in a patient with pulmonary embolism. And that concludes our video on hypoxia.